Hello, I'm presenting a case study 58 hypoparathyroid disease. The disorder is hypoparathyroidism. My name is Paulson Elekuru. Patient case introduction. The chief complaint uh, the patient stated recurrent and painful muscle spasms of the hands and feet and dry, scaly, puffy skin. She further stated that I have not been myself for the past 4 to 5 weeks. The history of present illness. The HPI AW is a 50-year-old white female. Present to our primary care provider with the chief complaint of persistent and painful muscle spasms of the upper extremity and lower extremity, dry, scaly, puffy skin. And she stated that I have not been myself for the past 4 to 5 weeks. When asked to further explain, she replied that in the past weeks, she sensed being very irritable, combative, and aggressive. She was involved in heated arguments with some family members and long-term close friends. Hypoparathyroidism description and epidemiology. Hypoparathyroidism is a metabolic disease of heterogeneous group of etiologies and is clinically a low level of PTH in the setting of hypocalcemia and hyperphosphatemia. There are two types of hypoparathyroidism. The primary, which is due to genetics, and the secondary, which is due to other disorders or destruction of the parathyroid tissue. In the United States, the prevalence of hypoparathyroidism is estimated to be between 24 and 37 per 100,000 uh, people years, mostly related to complication of thyroidectomy or head and neck surgery. Globally, it is overall deemed a rare disease affecting less than 1 in 1,000 to 200,000 people. The genetic causes are more common in children. The complication of neck surgery, they are more common in adults, especially women, due to their higher incidence of neck surgery with 12.3% to 3.2% in men, which is uh, 12.3% in women to 3.2% in men, which is a ratio 1 to 4. A lot of women, after delivery, maybe a couple of children, they have uh, thyroid disease, maybe hyperthyroid, and they have to do thyroid surgery. Pathophysiology of hypothyroidism at the cellular level. The causes of hypothyroidism include transient or permanent postoperative complications of thyroidectomy or head and neck surgery, which is 75% of the cases. Congenital malformation of parathyroid tissue, for example, in the George syndrome. Autoimmune destruction, for example, in polyglandular autoimmune syndrome, and autosomal dominant hypocalcemia, which is activating mutations of calcium sensing receptor or activation of autoantibodies of the calcium sensing receptor, which destroy the autoantibody destroy the calcium sensing receptor. Hypomagnesemia can also be a cause. Also, the infiltration of the thyroid parathyroid tissue, which is maybe as a result of granulomatous hemochromatosis or granulomatosis, and can also be caused by metastasis of cancer tissue from another tissue or distant tissue. Radiation, it can also be caused by radiation injury Parathyroid hormone resistance is another cause, which is termed pseudo hypoparathyroidism or inactivation of uh, or mutation of the G alpha subunit of the parathyroid hormone receptor. Genetic hypoparathyroidism may be because of developmental defects spanning multi-organ, originating mainly from the third and fourth pharyngeal pouches, or gene mutations encoding for major proteins specific for parathyroid tissue development and function, and mutation in the gene that modulate adaptive immunities tolerance mechanism, leading to non-surgical destruction of the parathyroid tissue. Another cause may be as a result of mitochondrial disorders and other causes, which also genetic. Genetic disorders can originate from germ cells or post-zygotic somatic mutations. One thing is that the later in the stages of life, for example, if it affects uh, a zygote in the mother's womb, then it can also not just restricted to parathyroid tissue only. It can be a general thing. It can affect the heart. It can affect other things, including parathyroid tissue. But if a child is born or a child is 12 years old, is the disease is specific, the genetic disorder is specific to parathyroid tissue instead of other organs. Clinical manifestation pertinent subjective data. The chief complaints, she stated recurrent and painful muscle spasms of the hands and feet and dry, scaly, puffy skin. She further states that I have not been myself for the past 4 to 5 weeks. The history of present illness as detailed above. Past health history. 20 years ago, she was diagnosed with systemic lupus erythematosus. She has a history of chronic alcohol abuse. She takes 1 to 2 week. She had 1 to 2 week admission to alcohol detoxification unit in a hospital. 4 years ago, she was hospitalized due to leaking cerebral aneurysm. Multiple malignant melanomas was removed surgically primarily on arms and face. She had hospitalization twice in the psychiatric unit for suicide attempts or suicide ideation. 29 years ago, she had ligation after birth of son. The family history: father died at age 70 uh, due to pancreatic cancer with bone metastasis. Mother died 2 weeks after father from a complication of heart failure. Young sister had history of bipolar disorder and suicidal ideations. One older sister and one younger sister, they are alive and healthy. Brother died at age 38 due to acute myocardial infarction. Two brothers of ours died due to lung cancer. One brother died following birth from hydrocephalus. The family history of alcohol abuse, she has that. All children put in foster uh, homes because of their parents abusing alcohol. They were adopted and foster homes. She has personal history of sexual and physical abuse. Social history. Uh, Formerly, she worked as a certified nursing assistant. Later she became self-employed as home health nurse aide. Uh, Currently, she's not been working for the past 6 years due to technical disability, maybe as a result of the systemic lupus erythematosus. She's receiving social security benefits. She was divorced twice, now currently living with a female friend. She has two children, but they are estranged, son and daughter. They live in other states. She smokes 1.5 packs of cigarettes. She has like 4 years smoking history. Like I said, 1.5 packs. She drinks 5 to 6 cans of beer per day. She eats less due to infrequent hunger that may be related to excessive alcohol use. Medications. She takes OTC, over-the-counter medication for occasional heartburn or GI distress. Uh, the NSAIDs she takes a non-steroidal anti-inflammatory drug that she takes for arthralgia, flare-ups secondary to lupus. Allergies. She has no known drug allergies. She's allergic to sun. It causes the SLE or erythematosus and macular rash on sun-exposed skin related to SLE. Pertinent objective data. General appearance, wearing glasses, very thin, walk, weak and frail, white female with no apparent distress. Seems to be significantly malnourished, in good spirit, cooperative, alert oriented, times 3. Vital sign, uh, they are normal, and our temperature is 98.5, the weight is 97, the height is 65 inches. Physical examination review of system. Denied thyroid or any other types of neck surgery. Constitutionally, she has significant fatigue and weakness, poor appetite, neurology, occasional headaches and dizziness, no fainting spell, unsteady gait or seizure. Neck lymph node, they are normal, no lymphadenopathy, HENT within normal limit except for left pupil with no light reflex, suspect ADs or pupils. Uh, the chest, lungs, they are within normal limit, cardiac, respiratory, and breast. And neuro, the muscle tone is 4/5 throughout. She has positive Chivostek sign bilaterally, and lower extremity, she has multiple scale bilaterally, and surgical excision, mild edema, lower and upper extremities. Uh, the skin has it's very pale, dry, and flaky. No ecchymosis or purpura. The diagnostic lab they are shown on the PowerPoint screen. The role of the party, advanced practice nurse underpinned by the Christian worldview, the APRN plays a critical role in ensuring proper management of hypoparathyroidism as follows. Number one, development of validated tools for measurement of quality of life, e.g. disease burden and efficacy of treatment, including cognitive deficit, fatigue, physical endurance or muscle strength, muscle cramping, tingling and muscle spasm, switching, fatigue and cognition, as well as anxiety, sadness and depression, and impact on sleep, and ability to exercise, ability to work, and family relationship. These are to be measured so that uh, intervention can be designed. Uh, One of the two is hypoparathyroidism symptom diary. As the APRN is to assist in choosing between conventional management of hypoparathyroidism, including oral calcium intake, e.g., calcium carbonate or citrate, and active vitamin D treatment, e.g., calcitriol, and thiazide directed to elevate calcium reabsorption at the distal tubule, and magnesium supplement PRN, or parathyroid hormone therapy, intermittent parathyroid hormone injection. We're to note that signs and symptoms of hypocalcemia and decreased quality of life are common with conventional therapy. Education to prevent fractures due to complications such as skeletal fracture related to reduced bone mineral density, e.g. spinal fracture, and renal disorder related to hypercalcemia that may cause renal calculi or chronic kidney disease in the long term. To provide education about calcium fluctuations that can be triggered by exercise, general illness, or unpredictable causes. Patients may benefit from realizing their calcemic variability in real time, so they can have opportunity to adjust their treatment promptly. Question: what clinical manifestation in the patient in the histories may be associated with hypoparathyroidism? Number two, what's the most plausible cause of hypoparathyroidism in this patient? Number three, how could this patient be managed pharmacologically? The last page is just the references. Thank you.